So welcome along to the third episode of our conversation about menopause and how we can do it better. Today we're going to look specifically at hormone replacement therapy and what we can do to kind of manage our vaginal microbiomes. Okay, so thanks both for joining me again for our third conversation in this series. So as has become normal, I think we'll start with some introductions. So I'm joined today by Dr. Jan Rogers from Agile Life Sciences and Dr. Helen Keeney. So Jan, over to you. Would you just like to introduce yourself to the audience, please?
Yes, absolutely. So I'm Jan Rogers. I'm the joint CEO at Agile Life Sciences. Been researching and developing the MenoGuide test for the past couple of years. And we're here to talk about sort of all things vaginal microbiomes and menopause, I think.
Great stuff, thank you. And Helen?
Hi, my name is Helen Keeney. I'm an NHS GP part-time and also co-founder of Flourish for Life, a clinic around lifestyle medicine and women's health. And I'm clinical advisor for Agile Sciences, and we're here to talk more about hormones, menopause, and learn more about the vaginal microbiome.
Great stuff, thanks both. Well, let's get straight into it. So today I was keen to have a little bit of a conversation around some of the, treatment options and potential sort of lifestyle medicine interventions that people can make in order to, make menopause as bearable as possible for some. So can we start with HRT? Helen, I'm looking at you on this one. HRT, what is it? What does it mean? I think there are some people that are still very nervous of HRT, so it'd be just good to understand the different types of HRT and the options out there for some people.
Yeah, and I think you're right, Beth. It's about looking at that menopause transition and taking it on an individual basis, isn't it, around what that individual woman needs, able to take and wants to take, and then having the knowledge around what hormone replacement is and how it can be used for a lot of women, and it can be helpful. So you mentioned hormone replacement. In this country, it's called hormone replacement. In other countries, it's known as MHT, menopause hormone treatment. And that basically, obviously, during our transition, as our estrogen levels are fluctuating and declining, the hormone replacement is replacing the estrogen just to try and help with some of the symptoms that women experience during the menopause. So certainly vasomotor symptoms, hot flushes, so quite a lot of the sleep disturbances and some of the mood-related disturbances related to menopause transition can be helped quite significantly by replacing hormones. And the idea is to replace those at a low level and then obviously replace those up to the level that controls those symptoms for women. And hormone replacement, typically, obviously we can expand on it, comes in. We talk about replacing the estrogen, and that estrogen helps with the symptoms, but as one of the side effects of estrogen is it can increase the lining of the womb. So it's really important for women who've still got their womb that we need to protect that lining. So for some women who might need contraception as well, the Mirena coil, which is a coil that sits in the womb, can help that. It can help thin the lining of the womb, protect the woman from build-up of the lining from the estrogen, and also work as a contraception. And then some ladies take a tablet form of the progesterone to help. So you've got the estrogen that we know is the safest way of giving it is through the skin, so transdermally, so that can be a patch, gel or spray. And then that's very individual to what patients prefer depending on the delivery. And then we usually start patients on that combination and say, in 2 to 3 weeks, we might see an improvement in symptoms, and then we titrate it up depending on individual patients' response, but it can take up to 3 months to see the initial response for that first treatment. And then obviously the third sex hormone that some women notice that can have an impact is testosterone. Mm-hmm. Currently not licensed in the UK, but we see it has got guidance through the NICE guidance around low libido. And some women find that after we've established people on hormone replacement, if they're still noticing symptoms, then that can be a useful added bit of the jigsaw that people need. But like you said, it's so important to look alongside that, the lifestyle perspective, because for every woman, and it can be a really challenging time in midlife, like we've talked about before, that there's lots of other factors that could be either worsening menopausal symptoms, not be menopausal symptoms, and we need to be looking at patients in a holistic way at that stage. So hormone replacement can be part of the answer. But yeah, I think there can be a lot of confusion around it. So I think it's worth kind of myth busting a bit.
Mm-hmm. Because I think one of the things that I observe is that some people think HRT is going to be this magic bullet that they're going to be prescribed. Perhaps some of them have fought with their GP to get that prescription. They get the prescription, and 2 weeks in, they're seeing no improvement in symptoms. So you said it can take up to about 3 months.
Yeah, absolutely. And I think you're completely right. I think it's been great. There's been, greater awareness, menopause awareness, on social media from celebrities and things. But I see it in my own practice. A lot of patients, feel that that's going to be the answer. It's going to be that magic wand. And I think it's talking about, actually, because it is such a complex time to try it, but also, yes, to have that perseverance if you do try it, that how that could be for you as an individual. So for the first 3 to 6 months, it's quite common to have, side effects. You can have breast tenderness, you can have some irregular bleeding, you might feel, some women experience a bit of nausea, headaches, and then actually majority of those symptoms do settle down, or we can start you on a lower dose and titrate up. For a lot of women who are able to take HRT and there's no reason not to, for example, active breast cancer or anything like that, there certainly usually is a delivery method for you. It's just a case of, it can take a while to get that right. And I say to a lot of ladies, it's going to take us a year. We're going to get this right, but you're going to have to just bear with me a bit.
Mm-hmm. Okay.
Can I ask a question?
Of course.
All right. And this may be too sciencey, so please tell me if this is wrong. But is there the drop-off in estrogen? I mean, we kind of know it's not linear, and that's the big issue, really, I think, is it fluctuates. But is that the same with progesterone and testosterone? And is the ratio that how we replace that the same all the way through? So, one patch always has a 1-to-2 ratio or a 1-to-3 ratio, or does that vary? Can you vary it? I
think that would be brilliant if it could be that scientific. And I think I think the difficulty is we don't have that. And I think you're right. I think all the sex hormones do drop off. Uh-huh. They never stop. I think some people describe it as a deficiency state, and that's actually quite hard, because I'd probably say we're dealing with a natural process, aren't we, of fluctuating hormones and then reduction. And if you've still got your adrenal glands, you've still got your ovaries, they haven't been removed, you're still going to get a low level of all those hormones. They're just going to be reduced. So a lot of women actually find they get a lot more symptoms during that transition and on the decline. And then once they steady out, for a lot of women, they actually symptoms do settle. So the replacement has to mirror that. So for a lot of perimenopausal women, we end up using higher doses. And then sometimes we have to then, quite regularly then, that's why we review patients every year, just to start reducing that down if patients are well controlled with symptoms. But then again, it's that shared conversation between women. So, I quite regularly chat to ladies that I look after, and they say, actually, I'm okay. I just want to carry on as I am. And, assessing risk. And I think, possibly going on to risk, then it's really important to always assess an individual woman's risk. And that changes as we go through life, what happens with family history, what happens with our own history. So, we do a full assessment of that before we start on hormone replacement, recent risk of blood clot, breast cancer. You can't be on hormone replacement if you've got active liver disease. There's a number of different things you have to consider before doing it. And, it's not for everyone. Some people hear that and they balance that and they prefer not to take it. And some people who, like we mentioned about breast cancer, aren't able to take it if you've had active breast cancer. It is a contraindication.
So is the coil potentially a solution to progesterone, I guess, as you enter into perimenopause and potentially even postmenopause? Is that?
I mean, the coil, the Mirena coil, so the progesterone coil that help, so that can certainly work well for a lot of women who are maybe struggling with really heavy periods, or they've become quite irregular. That can help switch them off, and it can obviously work not only as contraception but the progesterone arm of the hormone replacement. But if you've got any significant symptoms, they tend to be as a result of estrogen fluctuations and reduction. So replacing the estrogen alongside it tends to be the solution. But I've got some ladies who, as they are almost premenstrual to perimenopausal, that time can be a bit confusing. And actually, if their main symptom is heavy periods or anemia related to the heavy periods, the Mirena coil can be a really good first step.
Okay, so I want to come back to talk about those ladies that can't or choose not to take HRT. But just to conclude the sort of HRT discussion, so I've got another probably 3 questions. So the first one is around the kind of the historical myth. So if I think back, she's not going to like me for this, but probably 20 odd years ago when my mum was going through the menopause, I think that probably coincided with the sort of scary publications. And I can remember her then choosing to come off it. And I think that view still exists across the population so that HRT is dangerous or is really bad for you. So it'd be good if we could just understand the old HRT versus the new HRT, because I understand that they're quite different products.
HRT was widely used. It has been widely used from 1960s. It was used regularly, and then some studies started in the 1990s and onwards, and some of the initial reports came through around 2002, and it was the Women's Health Initiative and others that actually started showing. They took some headline numbers, didn't they, really, from the studies saying that, it caused breast cancer and, an excess in cardiovascular problems, so heart problems. And what that did was created a huge amount of fear, both in the medical community and in the, in the public domain. And a lot of people put their HRT in the bin, overnight. But actually, when they dialed back into the research and looked at it, the studies were done on much older women. It was done on oral estrogen and progesterone, and a lot of them had already potentially pre-existing problems anyway. So that's all been really looked at now. It's been concluded.
And wasn't it a different type of? Wasn't it, in my head, out something from a horse?
Yes, it was. It was the old conjugated estrogen, from pregnant mares' urine, and all of that obviously is so different to what we use now. And so I think it's been concluded that a lot of that was misinformation, really.
Yeah.
And I mean, there's a lot of good learning from those studies, but what it wasn't on is the current body identical hormones that we use now. And I think from all the research over the last 10, 20 years, we've realised that having estrogen ideally transdermally through the skin is actually very low risk. It actually doesn't increase your risk of clot. The actual risk around breast cancer, if you're on estrogen only hormone replacement, so if you haven't got a womb and you don't need that protection from the progesterone, there's actually less risk of developing breast cancer. And to put the risk in perspective around hormone replacement, you're more likely to have breast cancer as a result of being significantly overweight or having a couple of glasses of wine in the evening than you are from hormone replacement. So I think the advice is, as long as you're within 10 years of finishing your period, so your menopause, the risks of starting hormone replacement are low, and it's a case of balancing that. But obviously, again, like you mentioned, Beth, it's kind of individual if you want to chase it and to try it. And I think it is, if you haven't got any contraindication, it's a sensible first line treatment for the majority of menopausal transition symptoms. But again, alongside that, if you didn't want to take it or you weren't able to take it, lifestyle modifications advice can be significantly helpful for the majority of the symptoms. And we've got non-hormonal treatments, so treatments that aren't hormones that can help with specific symptoms like the hot flushes or with the mood changes.
Okay, great.
Are there any oral HRTs?
Yeah.
There are still, so you can still take
some
oral.
women. So there's a new product out called Bijuve, which is actually the body identical hormones. So the estradiol and the progesterone that we use actually is a tablet.
Oh, okay.
So they actually think that's got a very low risk as well, because some women just don't like using things transdermally. They prefer the oral route. And then I've got some ladies that are still taking oral because they've just tried the transdermal, it didn't work for them, or they've just asked never to change, and they take on board that's that increased risk. And again, that's that risk benefit. But I'll be honest, just recently we've done an audit in our practice and had a look at anyone on oral and gone back to them to have another conversation, because I think it definitely is safer to have it through the skin.
Mm-hmm, mm-hmm. And again, is that because I understood sort of the a lot of it gets processed through the liver and the kidneys and things. Is that sort of where some of the
if you take it orally, you have to have a bigger dose of estrogen and progesterone, because you have to have it, then it's processed through the liver and metabolized, so it has to go through, so you get that. So by putting it through the skin, you avoid that first pass metabolism, so that works really well for women. And also, I think practically it's quite a nice approach, because we are trying to just replace normal levels, so it feels for a lot of women actually more acceptable to have a topical preparation rather than a tablet, because a lot of people don't want to be taking tablets.
And from a very personal point of view,
yes,
do people have? I mean, I'm kind of guessing everybody has a slightly different skin, and we all know that menopause impacts on skin biomes and things like that as well. But some people really struggle with the patches to stay on, and then some people don't. Is that, you think that's skin related, or is that
it must be, because I've got some ladies that are swimmers, they were in the water all the time and they don't come off at all. But I had one lady yesterday, can't even keep it on, I think some lady who are having a lot of flushes and sweating, that does have an impact with the adhesive. Okay. Some women, I've got a lady who's got quite significant eczema and it just irritates it. So she's rotated it until fortunately she came back and we made a change, because she's creating all sorts of skin problems. So again, I suppose that highlights how individualized it needs to be and how we need to be quite careful about, hearing something on the radio or hearing something on the news and then just saying, actually, I need that. So a lot of people come in asking for the gel because that's become very popular, but actually for some women, it's possibly not that practical if they need higher doses.
So there's a need for lots of regular monitoring and lots of conversation between healthcare practitioner and patient to make sure that what they're getting is working for them. Yeah,
and I think that can be done in a number of different ways. So you could have a lot of our practice nurses are really skilled up now to have that conversation, and it tends to be, if you respond well to it and you to that initial advice around the dose, it can be a prescription review in 3 months and then 12 monthly review. And that to me is the best. But a lot of women do need a little bit more support and advice, certainly in that first year, getting things settled down.
Mm-hmm. And one of the things that we've seen from our research, I would say, is that we see quite a variance in terms of how long somebody's been on hormone replacement therapy, when they started. Is there a kind of consensus as to when is the best time? Should you be waiting for your last period? Should you be trying to tackle symptoms as soon as they start? What's the kind of feeling on that?
I think that's really interesting, and I think your research is going to be really helpful potentially for that, because is it going to show things early? Is it going to show things? But really it's down to that individual woman, because obviously we know 1 in 4 women might not have any symptoms, 2 in 4 might have quite impactful symptoms, 1 in 4 significantly impactful. And as I say, it's a natural transition, isn't it? So I would say if a woman is feeling significantly impacted by their symptoms or impacted enough to want to have a conversation around it and should have a conversation around it, then we need to start thinking, do they need to consider treatment? And that could be through their perimenopause. It could be at any point through their menopause itself, so when they've not had a period for 12 months, or it could be up to 10 years after you've stopped your periods in menopause. We call that the window of opportunity. So we know that there are lower risks of starting hormone replacement within that time. We're less likely to encourage us to, women to start after that, because there is a slight increased risk of stroke. So and obviously our risk of breast cancer baseline risk goes up as well. So there's and cardiovascular risk. So there's a lot of other things to think about. But I would say there is no definite specific time that you ought to start it. If you are experiencing symptoms, I think the first step is to think, what can I do here to understand why I'm getting these symptoms? So if, for example, it's brain fog, yes, it could be caused by some fluctuations in hormones, but it could also be caused because you're not sleeping very well, or your diet maybe has got quite a lot of processed food in it and things like that. Now it's about looking at all those individual things, and that can be hard if you're struggling with menopausal symptoms. So you might need some support around hormones to be able to address some of the lifestyle things. And it's just really important to have a look at someone as an individual, but have a conversation with someone around it. But yeah, definitely no specific time.
Okay. And so just to conclude the kind of HRT discussion, what about those ladies that can't, making a conscious choice not to take HRT? I read quite a lot about some ladies that want to just manage it naturally and kind of go through it that way, because after all, it's a natural process. Yeah. So this isn't about almost medicalising the menopause. I think
you're right. I think it's about supporting women with their choice, isn't it? So if women are keen not to take it or unable to take it for whatever reason, then it's about finding out what symptoms are impacting on them, if at all, and then explaining what this transition, what's happening to your body, because I think understanding and awareness of what's happening to yourself is key. And then working through with women on how we can best help support them with the treatment. It might just be lifestyle. So we talk obviously about the pillars of lifestyle, looking at how they're sleeping, their nutrition, their physical activity, all those things, managing stress, looking at inflammatory levels, managing, obviously we're learning more and more about the inflammatory impact, and we know that reduction fluctuations and decline in estrogen probably is likely to give you in a more inflammatory state. So education, I think, is key at that start, and then listening to the patient really and saying, what can I, do? I've got one lady who it's the mood disturbance, but she's not able to take HRT. And we've talked about that, and we've done all the work. She's had some talking therapy, and actually the conclusion was she had a trial of antidepressants, and that's helped, and it's worked really well. And I think there's a lot of conversation around hormone replacement at the moment, and I think we need to have more of a measured. Actually, there are lots of solutions out there, and a lot of those solutions and there's a lot of women. 1 in 8 of us, 1 in 7, 8 of us are going to get breast cancer. So we need to have a balance of. It's not always about hormone replacement.
Definitely. And I think it's about the kind of the holistic approach. So thinking practically, is there any sort of, I don't know, top tips around somebody that's struggling with sleep, is struggling with stress levels? And I think, the other thing that's probably really obvious in some respects are women of the menopausal age are probably juggling a lot of things. So, by definition, they're probably working, family, maybe caring for elderly relatives, a lot of spinning plates. So it's easy to kind of say, oh, you need to get on top of stress levels and get better sleep. But practically, what sort of things could somebody do?
I mean, I think exactly that. If you start telling people to sort of, right, you could deal with this and let's get your physical activity more and all the rest of it, you're just literally adding to overwhelm, aren't you? And that's not helpful. So I think the best approach is that holistic approach. It's about supporting patients to make little changes, maybe trying to carve out amongst their very busy day a bit of self-care time. So, and that can mean very different things to different people. So for some people, they might want to go for a run, but for some people, it actually might be 10 minutes of a breathing, techniques or some yoga, or it could be, I have a lady this morning I saw and she really likes crocheting and that was massive for her, and she actually, what we discovered, stayed up really late to do it because that was her time, but actually that then explained why she was possibly not getting as much sleep. But then we thought, is there another time we could create that opportunity in the day? And I think some of us, we're all on a bit of a conveyor belt, aren't we? And I think if we can talk about optimizing hormone replacement, optimizing our lifestyle, but we are changing in that time. And as we get older and we're juggling a lot more, it's just harder. So I think a lot of us expect a lot. And so it's just about trying to, I suppose, use this as an opportunity, I think, to reset that balance. And I think there's a lot of almost negativity that surrounded that menopause transition conversation, I think, in social media, and it's about possibly making that and reframing it as this is an opportunity to put my self-care a bit higher up, and then working out how we can sort of figure things out around that, and possibly asking for that little bit more, because I think the women I certainly see, and I think we're all guilty of it, trying to do everything. Yeah. So I don't know what you think about
No,
that.
absolutely. And I think, there's the trend towards the managing menopause in the workplace, I think, is also critical, because I think, to your point, it's managing expectations, really. As individuals, you can't do more and more and more. And I think it's about even in the workplace, about managing what we can do. And, I think it's, we have a day when we should work, and it's through that, beyond that is really, it's about managing, I think, from an employer's point of view, making sure that's all understood and expected.
And flexible, potentially. I've got some ladies that say, actually, I'm really struggling in the morning because I've had a bad night's sleep, but actually I really want to give my all to this job. I love my job. It defines me. It's part of my world, and they, having that flexibility, that understanding, that ability to have a conversation of what helps you. So there's a lot of great menopause policies at the moment, but it shouldn't be a tick box. It's like what I would need would be different to what you'd need, and all the rest of it. So again, back to that individualization. Yeah. And
I think we, our default is often, well, I've always been able to do that.
Yes.
And actually, it's taking probably a bit of a hard look in the mirror and being really honest with ourselves to say, actually, am I biting off a little bit more than I can chew at points? Yeah. And I think, and it's really difficult to do that.
Massive.
It's very easy to sit
especially
here
if you've got caring responsibilities, and if you've, and a lot of ladies like you described are juggling those two generations. And I think you see patients thinking that I just can't step off this, and I think that is when it's really difficult, and flexibility at work then becomes key. And
almost fear of failure, isn't it? I have always done it. Why can't I do it now, sort of thing? Without
absolutely.
Accepting that actually, I'm going through a different lifestyle change.
And some women, you see in lots of the research and in lots of the information that's out there, get to that breaking point and then see the only possible solution as being to leave their job.
Absolutely. Or step down. And
that's the one thing that probably for some retains an element of sanity. So it's really important, isn't it, to try and manage it before it gets to the point where you think that's the only option.
And it's about connection, isn't it? So it's connection with yourself, it's reflecting that. So that's one of the pillars, isn't it? And then connections with others, and work is a massive pillar of that. So it tends to be when I'm seeing patients who are wanting a sick note, or they're starting to step away from work, or stress related, that's usually when other things have fallen apart quite significantly, because we're all right to put a face on, we can just about, manage everything. So that's a massive red flag for me. And unfortunately, that tends to be a lot of the times when we do see people, because they are just treading water and keeping going. So, I think the more we talk about it, certainly from a what can we do? So if we can understand it, put a lot of these strategies in place ourselves, how do we optimise our own lifestyle and areas that maybe we know that we're struggling with, like sleep, or and then, like I say, use hormone replacement or other treatments if necessary.
Great, thank you. I want to come back as well and perhaps tackle some myths, but Jan, I've got a couple of questions for you specifically. So one of the things I think we're seeing through our research, when ladies have taken the test, they've had their report back, and we talked in depth about the report on the last podcast, and we looked at the various measures and those sorts of things. One of the questions we often get asked is, so what can I do to sort of almost improve my vaginal microbiome, or how do I sort of get my numbers up for some women? So I'm thinking specifically those ladies that have got probably quite a dysbiotic vaginal microbiome. So firstly, if you could perhaps recap on what a dysbiotic vaginal microbiome might look like, and then we can look at perhaps some of the things that we're seeing.
Yep. So I think in the previous podcast we've talked about homeostasis, which is very much dominated by one type of bacteria, and then as we move into dysbiosis, that's the presence of lots of different bacteria, and predominantly not dominated by one specific bacteria. So that's really what dysbiosis is, and we sort of talk about how that happens with varying in the pH and other bacteria being present and proliferating. So I think what might impact on your vaginal microbiome to make it more dysbiotic, we've talked about the reduction in estrogen, and as you progress to postmenopause, that's most likely to be the main cause of going into dysbiosis. But there are other causes, and we talked sometimes some premenopausal women will have a dysbiotic biome, and those things can be, as Helen's already mentioned, lifestyle. So a lot of stress will really impact on that. Smoking, douching, using a lot of feminine hygiene products. All of those sort of have an impact and can have an impact. So I guess the converse of that is everything that Helen's already mentioned in the lifestyle management, reducing your inflammation markers, and then looking at diet. Smoking's a real sort of impact on your biome. Feminine hygiene products. I think
don't use them.
Yes, basically, somebody described your vagina as sort of a self-cleaning oven, really, which is the less you do, the better it is. And I couldn't reiterate.
That's all anyone's going to remember from this podcast now.
Brilliant. But that's kind of at odds with that's at odds with everything that we're fed, though, isn't it? You open magazines and
look at the counters in Boots. Everything stuff, isn't there?
Mm-hmm. And I think people almost then develop an obsession about cleanliness and wanting it to be clean and wanting it to smell fresh and wanting it to be an inviting environment. And yet, actually, that's probably the antithesis of what we should be doing.
Definitely, yeah. And I think, the less you do down there, the better, really. And anything that's going to impact on changing the pH, changing the flora. And, another key one is reduce the amount of sugar you eat, a bacteria and a yeast. Boy, did they love that sugar.
Couple, yeah.
You couldn't give them anything better. So again, it's more focused on what I think was already been mentioned, really.
And I think, we think about that in the greater context. We hear a lot about, the best diets are those that are whole foods, reduction in processed foods.
refined sugar, like we're saying. Yeah, absolutely. And I think a lot of women, again, back to that awareness and that confidence to go and seek help, though, because, those products are out there because people are getting symptoms. So, sort of getting more, through the transition as your estrogen levels are dropping, you can get quite dry vagina, but it can also get some unusual discharges. It can be different to what you're used to. It can be itchy, it could be sore. And so your natural response, rather than bother the doctor, because a lot of women just crack on, and is to go and start trying these products. So they can almost exacerbate the problem. And, 1 in 4 women, even on HRT, need vaginal hormone replacement. And so if you don't know that, why would you know to go and get the help?
And I think there were, some women are still really uncomfortable, aren't they?
Absolutely.
To go in and talk to their GP, particularly if, for some it's a male GP and that's their only option, to start talking. So they kind of then look to self-medicate and what can I get in Boots and those sorts of things.
And, I think that's a perfect example is if I get a discharge, I'm kind of getting the vast majority of people, because they can get it over the counter, will go to Canesten or go to a thrush or something like that. Whereas, it may well be a bacterial vaginosis, which again isn't, was it 1 in 3 people will suffer from bacterial vaginosis? So, it's a fairly common thing. It's just that it becomes what's accessible, really.
People treat for both, and I've got patients who say that they just use thrush treatments weekly, and it can't be that.
No,
we need
exactly.
to figure that out. So
Okay, so we might have covered this previously, but bacterial vaginosis, to me, as a non-scientific, non-medic, sounds quite scary.
So go on, you'd explain it.
Well, so, I mean, for us, bacterial vaginosis is the domination of one specific bacteria. Maybe it's Gardnerella, maybe it's Prevotella.
Is that a bad bacteria?
It's one that will leave the door open for other bacteria to proliferate, if that makes sense.
Nice.
It kind of just lodges the door open for the others to come in.
Yeah.
So no, not bad in itself, but and some people will suffer with a discharge, I guess, and other people won't suffer with a discharge.
Some women will have no symptoms from that. So the first thing you get if you do a swab, for example, is you say, have you got symptoms? But some women will describe like a light greyish sort of smelly discharge. They describe it classically as a fish discharge. It's usually quite a step change to what you're used to. But I've got some ladies that notice that premenstrually, and then it settles spontaneously. So, but there are now treatments over the counter. But again, back to your point, Beth, is like there's a lot of self-treating going on, which I have every respect for, because actually if you can, and it's just that and it's simple. But then obviously what we haven't touched on is that, there are quite a lot of sexually transmitted infections that can give you a discharge. There are other things. And then obviously, again, obviously the menopause transition can have an impact too, and your menstrual cycle generally. So,
yes.
Okay. So if it's not giving you any problems and you're not having any symptoms,
certainly bacterial vaginosis do nothing about
it. Okay, that's good to know. Excellent. And so on that sort of theme of kind of myths and things that people kind of come across, what are the other sort of top ones that you see or hear people talk about?
I think we've touched on the breast cancer. That's always quite a big one, I think, and that can sometimes be both the patient and the medic if they haven't heard, more recent updates.
I've heard it from medics, definitely, when we've been conducting research and in conversations that we've had. So I think there is still a prevalence perhaps in the medical community as well.
Yeah. So, and I think that's down to, unfortunately, education, isn't it? So we weren't taught it in medical school, and unfortunately that's that legacy, isn't it? But hopefully the tide is turning slightly. What other myths are there?
The one I hear quite a bit is, so all I'm doing is delaying it.
Yes.
So if I have to go through it, I might as well go through it now, sort of thing, whilst I'm still younger.
That's a good one, isn't it? So I think it's understanding that what you're doing is just replacing or topping up some of the hormones that are giving the decline is giving you the symptoms of. And so if you top those symptoms, those your natural hormones will be fluctuating and declining anyway. So you are essentially treating symptoms whilst that process happens. And then when you stop it, some women notice a bit of a rebound effect if you just stop it. So we do tend to wean down quite gradually, but it's not because you're delaying it. It's just that actually you probably got used to not having those experiences, and that's treatment. And then there is a change in hormones. We all notice a change when we change hormones. So yeah, absolutely. I think that's a myth, to bust. But and it's also back to Beth's point earlier, it was like, it's not something you just have to get through. I think there's a lot of women who just certainly come to me. I think I just managed. I got through it, and a lot of our mothers had that mentality, I think, and it was seen as a, sort of not a subject to talk about particularly at all. And then if they did struggle, it was very much, kept quiet and toughed out, really.
And I think when we look back, I guess, to that era, it was all that non-bioidentical. It was probably going through that period where HRT was considered a no-no sort of thing. So, you can understand why your sort of your parent, your mum's just went, just get through it.
And they had really busy lives, and that's not to take away from it, but modern life is busier again and different. So a lot of us are having children later. So you're going through your menopause when you've got teenagers in the house. You've got possibly...
now, so it's hormones everywhere.
There's hormones everywhere. That could be a really bad combination. And if you've got older, we're now obviously living longer, so our older relatives tend to have, more caring needs as they get older, complex conditions, and we're not living in communities like we were. So a lot of the times we're quite spread out geographically. So I've got patients who are trying to juggle a job, look after the children, and then they're travelling a couple of hours to go and look after mum who's getting frailer, and I think that's massive, But so modern day life stress is there are things we can do, but there are things that have just happened, haven't there, with time, and I think that is impacting on our health.
Another one that sorry, Jan.
I was going to say, do we know what percentage of women are on HRT, and how do we compare to other countries? Is that something that sorry, Helen, I've just thrown that in there.
And I how good I am at remembering a number off the top of my head, but I think the numbers have gone up for hormone replacement exponentially over the last few years since this raised menopause awareness, and as a country we are quite ahead of a lot of countries, and North America is quite high as well, again, since obviously they've sort of gone through the same process with the understanding about the misinformation around breast cancer, etc. But some European countries still struggling to catch up, and certainly in some of the different ethnic sort of groups and cultures where it's not really become sort of, again, talked about subject. I think there's lots of areas. It's really disparate. Like, there's definitely not a consistent improvement in menopause care across the world, without a doubt.
I think the last stat I read would indicate that it's still below 20% of women that are on hormone.
I think it dropped to like 2% overnight, didn't it, with the in 2002, and then it was, I think we got up to 20%, and then if we're back up there, we've got back up.
I think something in the teens, I think, but I wouldn't want to say for sure. One of the other myths that I've heard is about starting HRT too soon, and so
you get used to it,
and then when you really need it, it won't work anymore.
Yeah. I mean, that's a bit like the conversations around antibiotics, and that is real. If you use them, you don't, potentially you can create resistance, but that is not the case with hormone replacement. So your needs will change during your menopause transition. So your needs as a perimenopausal woman who is used to higher level of hormones may require higher level of hormones to get on top of symptoms or to achieve your more hormonal balance. But your natural hormones will dwindle and reduce, so your need will change. So you're not going to get used to your hormones. If anything, your requirement for hormone replacement will go down. But I've heard that a lot. Oh, I don't want to start it too soon. I better just keep going with what I'm coping with. In fact, I've heard that it's been said quite a bit recently. And I think that's because a lot more people are using it, and there's different understanding around hormones. Yeah.
And I think for some women, they think you can only be on it for 2 to 3 years or something like that. So
that might have been said from medical communities, as well, because we used to be quite fixed on a 5-year.
I was going to say I'd heard 5 years.
That was very much because a lot of the studies were 5 years. There doesn't seem to be a significant increase in breast cancer, but the understanding is, certainly from a perimenopausal point of view, that you're up to the age of normal menopause, which in Caucasian sort of Western communities is 51. Your risk, there is no increased risk. There's been no observed increased risk of breast cancer. So almost at the point when you get to 51, obviously our baseline risk goes up. So then you can start reassessing it on a yearly basis. And I think after 55 to 60, you're starting to look at, is this the need anymore? Can we reduce the dose? Where are we up to with that? And for some women, they will choose to continue it because they feel good on it, they feel okay, and they'll balance that risk. And that's a conversation. But for some women, actually, it might be time to come off. And a lot of women do very well after that.
Yeah.
I guess we don't really know the long-term effects, do we? I know we sort of talk about the benefits that may be long-term, but sadly, I guess the research just hasn't sort of got to that stage
We
yet.
haven't at the time.
We've started research now, haven't we? And hopefully in 10 or 15 years we'll get that data back. But there is the perception, I guess, around osteoporosis that staying on HRT for longer, there are benefits. But I don't know that I've seen the outcome of a lot of those studies.
I mean, we know that obviously estrogen is protective from a cardiovascular perspective and an osteoporotic perspective. And there were some claims around dementia, weren't there? But they aren't substantiated by good evidence as yet. But that would make sense alongside the cardiovascular risk, from vascular dementia. But again, we know our risk for cardiovascular problems goes up after the menopause because our estrogen levels go down. But it's complex. So if you've got significant obesity or you've got strong family history, you're more likely to then have a heart attack. So there is a balance. But I think the understanding is it's protective, but it's not that we can't make statements that you can be on it for life and there's no increased risk.
Yeah. And I think just jumping back to, I guess, what we do around the MenoGuide is, I think what that allows us to do as well is give us objective data. So, I mean, our goal, I think, at Agile is really to start researching female health into these very specific areas, so we can start to have some objective data alongside, the sort of the individual impacts and how does it feel and whether or not there's a reduction in these things as well. Because then you can start to get correlations, I think, don't we? And and lifestyle. I mean, for me, I'm super excited about doing lifestyle management and correlating that to improvements in vaginal microbiome and seeing if we can correlate that to improvements in how an individual feels. So we do have that objective data.
Because the biggest thing and the biggest resistance is around behavioural change and and all the rest around lifestyle. Changing lifestyle's hard. It's not like taking a tablet or putting a patch on. It's hard. So, and like Beth said, it's really complex depending on the social situation and environment you're in. So actually, if you've got that measure and then you see an improvement, or it gives you that motivation to make that change, I think that's huge, potentially.
Yeah, massive. So I haven't got any more questions.
We can chat all day, can't we?
I know, terrible.
But I think just some really important takeaways really for me today is one size doesn't fit all. It is very personal and very individualised, and actually will need a bit of work to get it right for each individual, and that, lifestyle factors are key and really, really important. And I think they're important, aren't they? In lots of probably different facets of life and in terms of how that can influence your kind of overall well-being. And that, research is kind of key and that we need to understand more about lots of these elements, but that actually there's a kind of benefit risk conversation to have for every individual, which comes back to that point. I think it's super, super exciting, and I look forward to our next conversation.
Thanks very much, guys.
Thank you.
Thank you.